with the definition and classification, and actually definition and classification usually takes our time because we need to know what we are talking about. And the definition have been dramatically changed along the years. And when we talk about the last century, the arbitrary definition was mean pulmonary artery pressure 25, and that's what we would know, if you remember the era of aminorex and so on. Then the definition started to be changed, and actually there have been a major drift in the our understanding of the disease starting from 1998. So the mean pulmonary artery pressure would be 25, and the exercise was considered at that time. So normal left heart filling pressure would be less than the pulmonary wedge, less than 15. And the pulmonary vascular resistance was included at that time, and it was more than 3 Wood units. Then we have in Nice the Congress, World Congress, and they started to say that these pressures are very high, and we need to consider that any pressure above 15 is considered abnormal. So we came with the last, and at last we have the guidelines, which has been the last year. And now the definition of pulmonary hypertension, which I need to stress upon, it is a hemodynamic assessment by right heart catheterization. And when we go for assessment of the patient and the categorization, diagnosis classification should be reflected the whole clinical situation. But definition is a hemodynamic, and this means that we need to go through the right heart cath. And the right heart cath is mandatory in order to classify our patient. We need to know where is the problem, where is the obstruction, whether it is in the arterial, in the at the capillary, venular, or it is on the left side. So this is the updated definitions. And as I told you, the definition now came to mean pulmonary artery above 20 millimeter mercury. In order to be pre-capillary, we need the pulmonary artery to be 20 and the wedge to be less than 15. And as we said, BVR never lies, so we need the BVR to be high. The absence of pulmonary increased resistance actually denies the presence of pulmonary arterial hypertension. Then we come to the post-capillary, which is the venular or the venous side. We have two types. The isolated, in this case, we have the pulmonary vascular resistance is less than 2, or the post-capillary and the combined, and in this time we have a high pulmonary vascular resistance. So the presence of pulmonary vascular resistance increased. It means that we have inherited something, we have some changes, remodeling happening in the pulmonary vessels. And the question will remain whether when we have a pre-capillary element, but the pulmonary vascular resistance is normal. And I'm going to talk about this later on. Then the exercise actually was revisited again, and they have it chosen that mean pulmonary artery over cardiac output slope between rest and exercise would increase, increasing more than 3 millimeter mercury is a definition for pulmonary hypertension. Because the question was always that stressing usually relieves or reveals the disease. So exercise have been revisited, and many researches have been used. And actually this is very useful in case of HFpEF and left heart failure. It can reveal the pulmonary hypertension side in this case. This is a situation when we have a pre-capillary situation. However, the mean pulmonary artery, the vascular resistance is normal. These patients are having a huge flow. They have high flow, which is not associated with increased resistance. We need to focus on them and follow up them. So this is the recommendation: follow up of this patient due to high flow or increased intrathoracic pressure, like in congenital heart disease, liver disease, airway diseases, lung disease, hyperthyroidism. Keep an eye on this patient. They might develop pulmonary hypertension really later on. But in the absence of pulmonary vascular resistance, and in this situation, they don't need treatment. This is exercise pH and mean pulmonary artery cardiac output slope more than 3 millimeter, as I told you, is defining. However, when we go, and this goes with the prognosis, when we go to differentiate between pre and post capillary, they have elected that the pulmonary wedge pressure over the cardiac output slope would be much more specific, and this is actually an argument and have been defined in the last guidelines. So then we go to the classification, and this is the updated classification. And why we are classifying, this is according to pathophysiological, so whether we have remodeling or not, we have vasculopathy or not, clinical, hemodynamic, as I told you, pre-capillary or post-capillary, and also the therapeutic implication at the end of the day. So we need to know that these classifications are very important to put our patient in the appropriate group that needs special tackling and special treatment approach. When we go through the group 1, we have the idiopathic, the heritable, the associated drugs and toxins associated with connective tissue, HIV, the same. But you look here that the non-responders and the acute responders have been separated, and they have very special category, as you see in the red. And then pulmonary hypertension with features of venocapillary, pulmonary veno-occlusive, or pulmonary capillary hematogen, PCH involvement have been grouped in a special group, as you see here. So this is the vasculopathy that we are looking for the targeted treatment. So we have medial hyperplasia, intimal proliferation, plexiform appearance, and these pathways are sharing in this pathogenesis, and that's why the group 1 is the target of treatment. These have been proved, and actually this differentiate this group from the other 4 groups. Then we go to the acute responders and vasoreactivity, and this is very important to look at. Here is the vasoreactive people who can take calcium channel blockers and they vasodilate and they go in a very good way, in good shape. They are here, they have vasoconstriction. When we give the vasodilator, simply they will irrigate the lung and they are going to lead a normal life. They are a different phenotype, unlike the case with people who has remodeling and fixed narrowing and vasculopathy. When you give calcium channel blockers here, you are wasting your time, and that's why this practice is prohibited. We don't give calcium channel blockers empirically. We have to do vascular vasodilator test during the right heart cath in order to elect this group, and this group are going to live a different situation and different, we call them the super responders. The heritable group, and actually there have been many genes that have been visited. The most famous is PMPR. We have the SOX17, the CAV1, and the F2, and all of them are related to certain category of the disease. For example, the PMPR2 related to the idiopathic group, SOX17 now correlated with the congenital heart disease, and F with the pulmonary veno-occlusive disease. So revisiting the genes and this sometimes screening in the family can help to trace patients early and bring them to early treatment. Toxins have been upgraded, and we have now the definite associations, and on top of the list is aminorex, but we have also methamphetamines, as you see, and the drugs with data based on outbreaks, epidemiological case control studies, or large multi-center series. So this is very strong evidence, that's why it is definite. However, we have here the possible associations, including many of the drugs like the alkylating agents, leflunomide, phenylpropyrolenamine. So it includes a lot of famous drugs, and this is according to suggestion by multiple case series or cases with drugs with similar mechanism of action. So they are suspected to be causing the disease. Now with the group, which is actually this is a very difficult to tackle group, and it's very important to diagnose at first, because its diagnosis sometimes is not easy. The pulmonary veno-occlusive disease and the capillary hemangiomatosis. This is actually there is at the capillary level and venular level, there is remodeling, and this is a disease. But actually, when they go to the pathology, also the pulmonary arteries and the arterioles are involved. The problem with this group is diagnosis. They came with wet lung, they came with century acinar GGOs, they come with lymph nodes. I have seen cases diagnosed as sarcoidosis in such case, and the pulmonary hypertension is a hallmark. Bilateral pleural effusion. We need to be aware of this group, wet lung with precapillary hypertension and with this accompanying. When we diagnose these patients, actually they are listed for lung transplantation because the response for treatment is usually not guaranteed. So they are listed when they are diagnosed directly for lung transplantation. Now we go to the group 2, which is a big pool of cases that we have. Heart failure with its two kinds, preserved or reduced ejection fraction, valvular heart disease, and congenital or acquired cardiovascular condition leading to post-capillary pulmonary hypertension. Again, this is very important group to suspect and to elect. Most of these cases, we don't take them to the cath lab. Again, this is the diagram that I'm actually fond of, and I like to look at always. These are the group here in the left side, in the venous side. If you give vasodilators, you are going to let the blood go back, and when it goes back, it's going to the lungs, and you are creating pulmonary edema. That's why in pulmonary hypertension with left heart, we never give vasodilators. And you have to do right heart cath before you decide that this patient might need a vasodilator. And actually, when you look at the latest guidelines, you will look that comorbidities have been included. Comorbidities have been included because we have noticed that the patient's idiopathic group have been in older ages, that most of the registries, they are taking older ages, not the 30s and 40s like before. They are reaching the 60s. This is the average age now. And many of them have combined pulmonary and heart diseases. And when you give vasodilators, although they are typical precapillary, you are going to create some shunt. You are going to create some pulmonary edema. That's why the recommendation is to start with monotherapy, to start cautiously with these patients, and this can demonstrate this situation. Now, with the heart failure with preserved ejection fraction, actually, usually it is mistaken as idiopathic, and we have many cases, and it is a burden in order to differentiate. And I know there is a lecture about this topic, which I think it's very interesting. Then we go to the group of lung diseases, chronic hypoxic lung diseases, and as you see, it includes most of the hypoxic lung diseases that we know. And the issue is here, very simple. We don't treat this group, and we treat it very cautiously because the pulmonary hypertension is due to diversion of the blood from the hypoxic areas that doesn't have oxygen towards the working areas in order to keep the ventilation perfusion matching. If you disrupt this by giving vasodilators haphazardly and empirically, you are going to create shunt. And that's why, again, in patients who are pre-capillary, diagnosed well by right heart cath, who have some lung disease, they are a smoker, they are hypoxic. So these patients are categorized as cardiopulmonary phenotype. We need to be very cautious when we give treatment, and we start with monotherapy. Now with the obstructive and hopeful group, which is the chronic thromboembolic pulmonary hypertension, and the other groups like hydatid and malignancy in the vessels. So this is the group that can be cured actually, and I have 3 or 4 cases after in the arterectomy, they came to 19 and 18 pulmonary artery pressure. So the hope here is to diagnose this well and to alleviate and allocate the site of obstruction for the surgeon in order to operate. If the patient is not operable, we have the angioplasty, and Professor Abdulaziz Al-Hayya actually is doing the balloon angioplasty, and they have many cases done and successful. But don't forget that this is a systemic disease, and when we have obstruction in certain vessels, the cytokine soup is going to the same pathology that happens in idiopathic pulmonary hypertension, and then we can go for medical treatment. And in this case, the drugs that we have are not a lot. So I think Riociguat is the only drug that we have. These are the last group is the group that is not multifactorial and unclear, and actually the chronic renal failure with or without dialysis have been added. Pulmonary tumor thrombotic microangiopathies have been added, and fibrosing mediastinitis. Fibrosing mediastinitis might come after chronic fungal infection, and actually we have chronic fungal infection in Egypt you have to look for, and sometimes we get these fibrosing mediastinitis, not only histoplasmosis, with other causes of fungi. So I think this can conclude my work. Of course, in sickle cell anemia, there is multifactors, as you see here. In beta thalassemia, multifactorial, and we have no consensus on treatment now. I know also in systemic and metabolic disorders, LAM, which have been added to the chronic hypoxic lung disease. Sarcoidosis gained some interest in the last era. However, we have to be careful, and sarcoidosis might be mistaken with BVOD, and these are the mechanisms that might share in pulmonary hypertension in sarcoidosis, starting from fibrosis associated remodeling up to portopulmonary hypertension. In thyroid disease, the pulmonary hypertension is a comorbidity and risk factor affecting the prognosis. Of course, pulmonary hypertension carry bad prognosis for most of the accompanying diseases that come with. So this is my take-home messages. A new pressure level have been alleviated for pulmonary hypertension, more than 20 millimeter mercury, and we need to have a PVR 2 wood units. The long responders and the calcium channel responders must be determined. Also, patient with unclear or multifactorial mechanism was simplified. New insights for group 2, 3, and 4 have been addressed, and actually the comorbidities have been considered during our treatment in the straightforward classified cases. Thank you very much.
Thank you, Professor Ayman.